minute past 7:30, so why don't we go ahead and get started? Sorry for the delay. But good morning, everyone, and welcome to our weekly CMR conference series hosted at VCU. Very pleased to have Dr. Jennifer Jordan presenting to us this morning on CMR research and core lab considerations, sort of making sure that we all understand the nuances of using CMR for research and how you can tailor it to your scholarly needs. Just a reminder to everyone that these sessions are CME and MOC accredited, so don't forget to text the code to the number provided on the screen. We've got a little bit of a shorter timeline these days. You only got about 48 hours to submit your code after the session, so make sure you claim your credits. And then today's session is ASRT accredited, so if there are any MRI technologists in the audience, feel free to claim those credits as well. And so without further ado, we'll go ahead and hand it over to Dr. Jordan. Thanks again.
Thanks, Corey. Good morning, everyone. Happy to be here and talk to you all about some special considerations from the research and core lab perspective when we're doing cardiac MR. Today, we'll go through a little bit about accreditation and testing with phantoms and how we make sure that the scanner is scanning a true 8mm slice thickness. Then we'll talk about the role of core labs, particularly in clinical research, when they're analyzing for one or more sites in a study. And then we'll take a look at some considerations with respect to the protocols and image acquisition, and then finally the analysis. So our first step in quality control for our images really comes from our QC testing that we do, and that's regulated by the American College of Radiology. So all outpatient facility providers of imaging, medical imaging, that bill under Part B of Medicare physician fee schedule have to be accredited in order to receive payment for their technical component of these services. So clearly, I'm sure everybody in this audience belongs to a ACR accredited facility. And as part of the accreditation, ACR has the guidance that they can perform unannounced site visits to validate compliance with the accreditation criteria. And there's a lot of factors to this, but the one that in particular really pertains to what we're talking about today is the QC testing. So all facilities that apply for accreditation have to maintain documentation of their quality control program, and that has to comply with minimum frequencies of QC testing as outlined in the table below. So there's a list of the weekly QC testing that the technologists do, as well as an annual test that a physicist would do. So the weekly checks that we have to do for our accreditation is making sure that the table position is accurate. We've got our center frequency, things like low contrast detectability, artifact evaluation, visual checklist. The things that we do annually with a physicist are we want to make sure that the magnetic field is homogeneous, because that affects the signal and thus the diagnostic quality of our images. They're going to test to make sure that the slice position and thickness are accurate, that the coils look correct, they're connecting correctly, measuring correctly, and things like that. And as part of it, they kind of circle back and do an evaluation of the weekly testing to make sure that everything's following the track that they want. As part of the accreditation, 4 to 6 clinical exams have to be submitted that demonstrate these different components for whole body imaging. And when we look at the cardiac box in the lower right, you can see that we have to submit scans related to our black blood imaging, our basic imaging, which can be our localizers or other things like that. Then we want to do some delayed enhancement images and delayed enhancement with black blood. So this is all from the ACR guidelines here. Certainly, we do a lot more than this for our cardiac imaging, particularly with research. But this makes sure that the contrast and the different things that we're looking for are very apparent in our images. Depending on the type of scanner, one of two phantoms will be used, an ACR phantom, and the images and testing data are then used to assess that contrast and spatial resolution, the slice thickness accuracy, that there's slice positioning accuracy, lack of artifacts, those things that were in the table earlier. And that's all documented on a program visual checklist. So it's very nicely organized, very easy to keep up with. And you can see here are the two tables for the small phantom and the large phantom themselves. So, on top of everything else that I'm going to talk about today, it really starts here where we're making sure that the images are accurate, that the machinery and the way the technologists are getting our images are accurate and to the right standard. The next part of the talk, we'll go through the role of imaging core labs. And this is an area where I've spent a good bit of my career so far, and we're still evolving and still learning from different experiences. But there's a lot of commonality in core labs, and the role that they play in research is really important. So if we look at an environment scan, when we're doing clinical research, we have a shift in the focus from pictures to information to outcomes. We really need to make sure that we're getting the right information so that we can make these statistical inferences from the data. So there's a growing need for both standardization and quantitation. Quantitation allows us to find maybe a 5% increase in ejection fraction with an interventional drug, right? So we need to make sure that we're able to not just say the heart is pumping better, by what percentage, by what quantitation measure we're using. More and more, imaging is being used as a biomarker, particularly for subclinical secondary endpoints, so that we can see, for instance, a change in ejection fraction that's in a positive direction, but maybe we don't have as many heart failure cases, but secondary heart failure would be really rare in that population. So we wouldn't get but 2 or 3 patients who go into heart failure. So it's hard to tell if we reduce that or if it's just an anomaly in the population that we've enrolled. So using the quantitation and imaging as a secondary endpoint, a subclinical change, is really starting to take hold and is one of the major benefits for CMR. From a policy perspective, there's stunning technical advances, but we still are collecting evidence with respect to the appropriate clinical use and value. We have to, for instance, in cardio-oncology, we don't have any specific guidelines related to subpopulation we should image and at what frequency, other than for a few different types of cancer treatments. And that's just because we don't have the level of evidence needed for appropriate use guidelines. But that's something that's definitely a focus, and something that as a society, CMR is really helping to highlight areas where we need more research so that we can do work to improve the policy and the guidelines for CMR. And in clinical trials research, CMR plays a key role because it allows us to do this non-invasive data collection, and that allows us to assess the efficacy and safety endpoints, as well as things like disease progression and therapeutic mechanisms. So we can look for instance, if a anti-inflammatory drug is attenuating the size of the infarction scar after a STEMI. So we have this ability to really start to look both at the function, the form, potential mechanisms of what's going on with the drug or the disease. So CMR plays a critical role in clinical trials research. It also has the capability to really reduce the sample size needed versus other imaging modalities that have a wider variance measurement around things like the LV volumes or ejection fraction or mass, CMR has a much lower variance. And so when we do a power calculation, it's a pretty significant reduction in the number of patients needed to enroll. So while CMR tends to be a little bit more expensive than other imaging modalities, it can be really beneficial from that standpoint, particularly in something like rare diseases, where you may not have as many patients that you can enroll. You can get a study done with a much smaller sample size. There are a lot of great papers out there. I've highlighted one down at the bottom of this slide that talk about using imaging parameters as both biomarkers and endpoints. And the biomarker framework, when we evaluate one, really has three characteristics that we have to make sure we do. There needs to be an analytical validation, a clinical qualification, and utilization. Subsequently, we then have to reevaluate all of the preceding steps. So a sequence of interdependent steps, which will continuously inform each other, is how we get to a biomarker being validated and used. When we think about analytical validation, that involves the assessment of assays or techniques that support the acquisition of measurements, as well as establishing the range of conditions under which the measurement will give both reproducible and accurate data. It's important that the performance metrics include precision, accuracy, lab-to-lab reproducibility, and limits of detection with adequate signal-to-noise ratio. We also need to determine reference values. So you're probably very familiar with this with something like CRP or troponin. Those have all been analytically validated, and we have to do the same here with our imaging biomarkers and endpoints. When we talk about qualification, that refers to the summation of the available evidence about the biomarker and disease relationship, including its relevance, diagnostic, and prognostic value. So there's a causal relationship to disease pathogenesis that has to be considered, and that includes the therapeutic intervention effects on the imaging marker and the clinical endpoint that we're doing. And finally, for utilization, that is the contextual analysis of all of the other evidence presented on this slide with regards to the definition of the context for the biomarker's proposed clinical use. So in addition, factors such as prevalence, heterogeneity, morbidity and mortality of the disease, and the risk and benefits of the intervention have to be weighed here. There's a few other components about the importance here with respect to our imaging data. We really need to make sure that we have reliable and reproducible results. If we're doing a single center study, this should be reproduced and have similar findings at other sites if we're using valid imaging endpoints. And we need to make sure the validity of the results for the overall trial are maintained. One of the ways that we can help with the meeting these criteria is to do our research through a core lab, and that greatly reduces the variability. So if you have multiple centers enrolling in a study, they will send all of their imaging to one lab where there are trained analysts, one or more, who consistently draw the contours in the exact same way. And that helps reduce the person-to-person variability, even if you have different scanning systems, like different vendors or different platforms in your study. You can help reduce the variability by having the core lab read all of the scans. Now, locally, you'll probably have a physician do a safety read and a clinical read on the scans. But for research purposes, we will redo all of the contours and do a uniform analysis independent of the site. It's impossible to get rid of all of the variability, but we do have more control in a core lab and the ability to minimize errors in both the acquisition and the measurements. And I'll go through the acquisition in a few slides. When you have multiple labs and multiple people drawing contours, analyzing scans, you're more susceptible to random error and drifts in your measurement variability. So really what a core lab can do is enhance the precision of your study results through increasing the accuracy and trial efficiency while also reducing the sample size, and that's connected to the reduction of variability there. The improvements in accuracy can be so significant that they may alter a trial outcome. So if you compare, and we'll go through an example in a few slides, the same study, but use all of the local reads versus the core lab read on the scan, you might have a null trial if it's done locally, or a positive trial if it's done with a core lab. It can be that impactful. There are a few essential components of a core lab. The goal is going to be ensure that the imaging data is robust to answer the trial or the sub-study objective if it's not the main outcome. And the way that a core lab does this is through minimizing that measurement variability, which gives more precise measurements and increases your study power. A diagram down here shows a really nice example of the general workflow. So a core lab can help set up a study. It can evaluate what capabilities a site has, if they should be an enrolling site to the study. Do they have the right imaging capabilities, the right patient groups to enroll? They also will set up the protocol, train the technicians at the site, make sure that everything is set up to go as quickly as possible and with a very homogeneous start for all the sites. Then during the enrollment and follow-up, they are involved with the image transfer, processing, and storage of those images. They review the images and analyze them. They are in charge of the data management. So we make the measurements on the scan, they have to go somewhere. It might be a REDCap database or another type of database, but they are in charge of moving all of the data into the database for the statisticians. And then there's an ongoing process of both the quality of the images, the evaluability of the image, and the overall image review quality. So when we have scans that come into the lab, we are often not just evaluating the measurements on the scans, but we're looking for things like artifacts or changes in parameters. Did they not do a full slice stack on the short axis stack for the cines? We need one more added because they typically lose the apical tip at this site. So that's an ability there, an opportunity where this core lab can engage with that site and re-educate them, adjust the protocol, and make sure that going forward for the study, things are collected with the best case scenario. And then at study closeout, there's a process of cleaning the data, checking the outliers, and then transferring that data from the data management to the statisticians or the data control group. And then they help with the interpretation and the dissemination, as well as any regulatory support that's needed from the core lab. So here's an example of the impact of a core lab in terms of accuracy. So with the LV remodeling study, the LEVERM study, this was an echo core lab study. It involved over 756 patients at 32 sites. So right there off the bat, I'm thinking there's a lot of variability being introduced to the study. And the study was looking at the prognostic impact of LV remodeling post-MI in patients who have an EF greater than 40. So they did serial echoes, and they compared the local site reads, individual labs, versus the core labs. And you can see the individual lab p-values are here in blue for the different measurements of the study. And then the core lab measurements are highlighted in red. And for all of the individual labs, whether they were looking at the 3-month value or the change from baseline to 3-month value, were not significant with a p-value less than 0.05 for individual site reads. But by having the core lab, again, reprocess all of those images that had been done locally, you could see that the variability was reduced such that every single measurement here became statistically significant. So this is a really nice example of how the core lab can reduce the variability and improve accuracy in a study and really change the outcome. Here's another example. This is a comparison of 2 different trials. We had the Prospect trial, which was looking at some echo measurements here. They used 3 core labs. I don't know the justification for it, but maybe it was too much for 1 core lab to handle, so they split it down to 3 core labs. And they had evaluable echoes in the range per site between 37 to 85%, with an overall evaluable rate of 74%. They ended up having to discard all of the Siemens TDI measurements, and they had very moderate reproducibility. So the outcome of the study was it bad variables? Did we have bad data collection? Did we not execute the study well? There were things that it wasn't clear because there were multiple factors going on. But the statistics claimed that it was a negative trial overall. Fast forward to a few years later, we had the eValve study, which was a similar design, looking at 5 mitral regurgitation measurements, and they used a single core lab. Their overall evaluable echoes were 75 to 100%, with an overall rate of 88%. So it was a little bit more control over the input and collection of the data, potentially. They had much better reproducibility with correlation coefficients of 0.8 or better. And the outcome was favorable for the same device compared to what the Prospect trial had. So it was a positive study, things went on. So this is an example here of not just comparing the individual reads versus a core lab, but 2 very similar studies of an intervention. One used 3 core labs, one used 1, and both the selection of the endpoints as well as the reduced variability led to a positive study for eValve. So the imaging assessment of cardiac function really influences clinical decisions. Okay, this happens in our clinical scans as well as our research scans. But with research, we can look at things such as when timing of a valve replacement should be, or if there's chemotherapy regimens. So we can ask these types of questions with the research as well. And there's the potential to provide unnecessary and potentially harmful therapy on the basis of imaging. So we want to make sure that when we're doing our imaging, we're doing it with the right timing, and we're not altering the patient's care in any untoward capacity. Core labs also have the ability to help determine if trial eligibility is met. So an example would be the ACORN study, where they were enrolling patients with dilated cardiomyopathy who had, quote, significant MR. How do you tell if a patient has significant MR? You're going to image them. So the core labs did a research scan on all of the patients so that they could see if they were eligible to then enroll into the study. And you see a similar metric here for the Partner 1 trial. I think a big part of what we do as a core lab is to make sure that we're getting quality data in. And so one thing that core labs can do is provide a quarterly or monthly benchmark card of your total evaluability of the scans coming in, whether they're echo or CMR, PET, so you can set a threshold. And if a site's not meeting those, for instance, site E here, you can intervene pretty quickly, target that site, do some re-education. Maybe they had a change in their scanner system or software. And so it's an opportunity before you get to the end of the study to potentially change what's going on at a site if you're monitoring it or the quality during the study itself. The centralized review can also help detect errors that are related to things like I mentioned on the prior slide, new imaging equipment, but also temporal bias. So we review our data as a lab and make sure that, when we draw similar scans, that we're drawing them the same way. We're not kind of shifting how we draw things over time. If there's a new analyst, if you're doing individual site reads or the core lab read, we have that opportunity to do an education and train people and make sure that it doesn't cause any shifts in the data measurements during the study. And we can also look for protocol deviations. Perhaps on that benchmark slide, they just quit doing the 4-chamber, and that was a critical component. So you can do that protocol deviation, identify that something's missing, and then intervene with them. So it's a really nice way of making sure that some error is not being continuously introduced throughout the study. And the result is you have better data at the end of the study. One thing that's specific to CMR versus other core lab reads is that when we do CMR, more and more we're using our parametric mapping techniques like T1 and T2 mapping. And there are now several different types of phantoms that are made in gels with varying concentrations of gadolinium set to be different, quote, tissues. Normal T1 values for the tissues. And so you can scan this phantom. It's about 4 inches by 4 inches by 8 inches, probably. This is an example of the HCMR trials phantom. And they have published the quote unquote recipes or guides for how to make these as well if you have a lab that's capable of doing that. I know Gabby Capture also created the Times Phantom, and more recently a T2 mapping phantom that was published in JCMR. So we can use these phantoms to send around to the different sites if we have different scanners. And that allows us to measure every scanner's difference versus a ground truth, because by the SCMR guidelines, we need to have a normative value for our T1 and our T2 per scanner, because the field inhomogeneities, even if we're all scanning a Molly on XA50 platform, there's going to be slight differences in our normal T1 values. So that's where the phantoms are really beneficial. The HCMR study was a multi-center study, and they developed actually 50 of these phantoms for parametric mapping testing. And what they did is they had each of the sites scan the phantom, and they can have them scanned monthly or quarterly. One of the things that you'll take down when you do these phantom scans is the temperature, because that also can affect the T1, and the settings that you have the scanner at. And in each panel, the top graph shows the observed Schmally T1, and the bottom graph has the residuals along the y-axis. So we can see that in a green box here, we have a very nice tight line of the different tubes within the phantom of what was measured versus ground truth. So we have a really nice correlation here, almost line of identity. So this would pass. You can see the variability is pretty low in this Bland Altman down at the bottom. So this is a site that passed the phantom QA. On the right, upper right, we have another one that passed. The majority of these fell in line, but there was one outlier. You can see here I'm circling. And looking at the variance here, we see that outlier here. If that's not a tube of interest, where it's maybe that's the fat signal instead of the myocardial signal, we could consider this site to pass. It doesn't have to be 100% perfect, but we want to make sure the myocardial ranges are measuring what we want. So maybe in this case, that phantom, something was off in the tube, or some setting was not correct when they scanned it. The bottom two panels show two cases that failed. And you can see, if you look at the bottom part of the graph, you can see this drift where the variability gets outside of the acceptable range, and that's in the myocardial T1 range. And then on the right-hand side, the lower right-hand side, again, we see a lot of values outside the acceptable green window here. So these are really beneficial to have when you're doing parametric mapping, whether it's T1 or T2, particularly when you're doing multiple sites, so you can start to calibrate things. But even with a single site, it can be beneficial to have this.
Jennifer?
Yeah.
Can I ask you a question about how do you use that to calibrate your data across sites? That's what I've always struggled with parametric mapping and how it's reported in the data. You know, like you said, so if we have a person that gets scanned here and gets T1 maps and then goes a few hours to Roanoke and gets a scan and then goes out to Centera, you know, they'll get three different numbers. If you have this quality control data, can you use that to somehow homogenize how you report the T1 value?
Absolutely. Yeah, absolutely. Great question. Yeah, this was something that took a while to settle as a field, because we knew the concept of we should scan and center things, but how do we adjust it? Is it you know, VCU runs 10 milliseconds higher than the phantom, and Roanoke runs 10 milliseconds below the phantom, and we do an absolute number adjustment. We've actually had more guidance recently of reporting the values with respect to the Z-score, and that normalization, then your Z-score versus your phantom and your normal values. And then we compare the Z-scores across sites rather than the specific T1 values there.
Got it. So it's kind of like the INR of T1 maps. So do you can do that with just a phantom, or you also need a certain number of normal controls to be able to report that Z-score?
Most sites are going to use, for the clinical purposes, they're going to have the normal healthy volunteers. So you can do it with that. If you do it with the phantom for a research study, I would probably use the phantom route, just because you know that that's more of a ground truth measurement than a sample of some part of the population, which has more variability to it. So if I had the option to do a phantom calibration, I would go with the phantom myself.
Got it. Thank you for clarifying.
Yeah, great question. So in summary, the core lab has many advantages, but I recognize the disadvantages as well. So in terms of trial eligibility, we can make it a more homogeneous study. We can help focus on the intended study population for enrollment, but that does add some complexity to your study enrollment and can slow down the enrollment of patients and identification of eligible patients. When we're looking at the careful attention to the process and our ongoing quality assurance, that's going to give us high levels of measurability and reproducibility, but you've got to pay the bills, and so it does come with a cost to the study. And then finally, if you're doing something that requires blinding, either to a patient group or the study visit, a core lab can anonymize the images or relabel them so that when we analyze them, we are blind to the study group assignment or to whether it's the baseline scan of a patient versus the 3-month scan. And that can reduce bias in the data, which is really nice. Alternatively, we could do a paired read where we know this is the baseline for the patient, this is the 3-month. We want to make sure we're measuring apples to apples and same slices, that sort of thing. Typically, our lab will do a full blind analysis, and then we will unblind to the pairing to make sure the same number of slices are analyzed and that sort of thing. It does reduce the measurement consistency. Sometimes when you do this, because you require multiple readers who are looking at serial scanning, but if everybody is trained and you do a calibration for the lab periodically, that can help reduce this. and attenuate any measurement drift that might occur. So I think for most people, the advantages outweigh the disadvantages if they can afford for the research study to include a core lab. But certainly a lot of these principles can be taken into single study labs or multi-center labs where they don't have a core lab. If you can use some of these principles about retraining and monitoring, that will still help the clinical research outcomes for the study. Next, we'll move on to protocols and image analysis. Or the image acquisition. There's a couple of differences when we do our protocol setup and our acquisition that are specific to research exams rather than looking at just a clinical exam. I alluded to this earlier, but CMR can have a large reduction in sample size when we compare it to other imaging modalities such as echo. So here, this is a hallmark study from, everybody quotes, from back in 2000. I think we need to redo this with our modern imaging techniques now. But if you were to power a study around a 3% change in echo, or 3% change in EF, absolute percentage change, because of the standard deviation around echo, it would require 102 patients enrolled in the study. But the standard deviation for CMR is only 2.5 by this study. And so we would need 15 patients, which is an overall reduction in the sample size of 85%. So this is a really powerful slide to show some of the benefits for doing CMR, but we know that there's a lot of value in doing other modalities as well. And our lab's involved in doing multi-modality core lab work as well. So we'll do echoes and in a subset CMRs. We'll have PET scans with CMRs. So it's just you have to look at what the outcome is, what the questions of the study are to design. But certainly it's a nice factor when you're looking at things like this that you can power your study with less patients. So the potential increased cost due to CMR, which really isn't that much higher, the costs have come down. You might end up not needing as high of an imaging cost because of the reduction in sample size here. When we go to acquire things like the Cine stack, we need to make sure if we're doing serial scans that we're aligning the Cine stack with the mitral plane in the same way each time, because we don't want to slightly have a little bit less of an angle here such that we would include this volume here in one scan and not in another. We want to make sure that we line up things the same way every time. When we're doing things that require our 3 short axis slices, like our parametric mapping, a technique that we've implemented that's been really helpful has been our 5-slice reference. So we'll take on a 4-chamber and a 2-chamber image. We'll take that as our reference image. We will prescribe 5 slices across that, aligning the first slice with the mitral valve leaflets. And then we increase the slice spacing such that we reach the tip of the apex. We can even denote the difference, the overall slice coverage there. And then when we come back each time with the patient, if their heart's remodeled, if we're in a study like that, we know that we're getting the same kind of, we're getting, 30%, 60%, 90% along that axis, so that we're typically measuring the same amount of tissue in that slice. This does result in pretty nice reproducibility. We have cases where we put the mid-short axis slice from baseline to 6 months side by side, and you see the papillary muscles in the exact same place. So this has been a really helpful, very simple way to make sure that we're getting the same slice positioning when we do our 3 short axis slices. So we prescribe the 5 here, and then we only acquire the middle 3. We discard the rest. In terms of our post-contrast acquisition, if we're doing post-contrast T1 mapping, The timing from contrast injection does matter somewhat. We know that there's a steady state that gets reached around 15 minutes. There's not much change after that based on the T1 recovery curve. So we plan our studies so that we're measuring in a very consistent way time from contrast injection so that we get less of an effect of the timing influenced into the T1 measurement. Artifacts are a big part of research as well as clinical exams. They can lead to significant loss of the quantitation that's needed for clinical research study. So we carefully monitor these during the exam and reacquire as needed. So I think I gave this lecture maybe in the fall, know your artifacts. That's really helpful because we could miss a critical scan that's the primary endpoint for a study due to an artifact if we're not recognizing it and reacquiring it during the exam. And with funding lines as tight as they are, we don't have a lot of extra patients in a study. We plan for maybe a 10% loss to follow-up in a longitudinal study, but those patients, every patient who stays in the study, who's retained, their data point is very valuable. So we want to make sure we're recognizing things such as gating artifacts. So on the left-hand side, you have a retrospective cine stack, and on the right is the prospective gating, which does improve, in this case, a patient who had AFib during the scan. So the data set is improved by making that switch from retrospective to prospective gating for AFib. Another thing that we'll see that particularly influences measurements like parametric mapping is the RAP artifact. And so you have a case here where the RAP artifact is coming right through the left ventricle. If this is an LGE scan, it's going to really limit our interpretation of this wall of the heart. But if we reorient things, change the field of view, we can improve and get a very nice clear image there. Selecting the correct null point is really important. If you're doing late gadolinium enhancement, just like with clinical scans, you want to make sure that you're nulling correctly. So here's an example where in the top row, we have our magnitude images. The bottom rows are phase sensitive images, and these were acquired at a 3T magnet in a normal patient. So with a TI of 200 milliseconds in the left column, 300 in the middle, and 350 on the right, you can see that the signal intensity of the myocardium is high on the image that's obtained with the shortest inversion time on the left. It's mixed or mottled when we look at our 300, and then it's nicely nulled when we look at 350 there. So just paying attention to this can really impact, several of our MI studies and sarcoidosis studies are looking at LGE scans. And so we want to make sure we're getting really good nulling there so we can quantify the amount of infarcted mass. And I can say this because I'm an engineer, garbage in equals garbage out. So once we've gotten the protocol set and it's straight at all the sites as best as possible, and we're acquiring the data really well, we still have a lot of work ahead of us in a core lab with our image analysis. So we then, once the data gets to the lab, the images, we still have to do some image quality analysis before we take our measurements. So this is a paper back when T1 and ECV were starting to become more widely available. I think this is from Peter Kalman's two-part series on ECV. But he has a really nice example here of an image quality scoring from non-diagnostic to excellent. And not only are there visual examples of these different quality categories, but there's actually text-specific descriptions of the quality. So good quality might be that there are 2 to 3 pixels across the myocardium with less than 10% artifact or reduced wall thickness. And then fair has a different threshold. So it gives us specific metrics other than just that looks good or that looks really good. So I always like to go back to this, and when we do our analysis on mapping images or even on other quality, other styles of images, we typically score it and we assign a numerical value to this, like 0 to 5, or 0 to 4. And it allows us to enter that into the database alongside the quantitative number we get, like a T1 of 950 milliseconds. And then we can sort the data and say, well, there's an outlier, what's going on? And we look at the quality score and it was a poor quality. Okay, well, let's look at that image. You know what? We're going to make the cut point that we will only include in the analysis any scans that are fair, good, or excellent. And those that were poor or non-diagnostic, we won't include. So by scoring it and entering that in the database, it allows the statistician to very easily make that decision with the investigator without having to do a pull of the data and look at the images. Why is this an outlier? We can put the quality score and even a note into the database. That's been really helpful. We have a lot of use for the parametric mapping in our research studies. And what I'm about to say is very critical to clinical scans as well as research scans. But when we do a T1 mapping acquisition, this case I have Molly's scans acquisition shown. What we're doing is we're really getting a set of T1 weighted images. And we're trying to do that over multiple heartbeats in a single breath hold. And so each of these images then gets combined to make the T1 map. So if at any point the patient has a sharp inspiration and you see the diaphragm move, this myocardial annulus may be shifted in the image. And we have both the pre-contrast and the post-contrast images. And the software now inline does a motion correction and T1 fitting. And so we get our quote unquote, what I call the raw images, what is the native pre-contrast and post-contrast image set. Then we get an output of the motion corrected data set. And then finally, there's the fitting so that we get the maps themselves. And before I analyze a map, I always look at the motion corrected data set of 8 or 11 frames. And I play it as a cine because you can very easily go around the different segments of the myocardium in a clockwise fashion and just hold your cursor and make sure that you have adequate motion correction in each of the segments, because sometimes it will prioritize the septal wall and your free wall will not be as widely as strongly motion corrected, and you'll see a little bit of a wiggle in that motion corrected image. Well, when we take these images and we fit them, we're fitting the X, Y coordinate of 50 and 30. And we're taking it in each of these different frames and we're plotting it, fitting it, and creating the T1 curve. So if in any of these frames, the myocardium moves out of plane and you have a pixel that's myocardium, myocardium, blood, myocardium, 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 it's going to shift the T1 curve here. And your number is not very accurate, but your image that you get as an output when you look at the T1 map or the ECV map may in fact look correct. But when you look back at the motion corrected map as a cine, you can see that segments fail and you might not want to include that segment as part of reliable data set. The motion correction is overall beneficial. So this is data on using the motion correction in the pre and post contrast T1 maps to create the ECV. When we do a ECV map in normal myocardium without the motion correction, it has quite a high variability, but with the motion correction, it nicely reduces that variability. So the overall benefits of it are positive and outweigh the downsides, but we just need to make sure that when we're doing any analysis on a map, that we're trusting the underlying data that comes from it that we've acquired. A few other image analysis considerations as we wrap up here. There are differences in the acquisition. For research scans, we're often working with WIPs or works in progress. C2Ps is another term. These are all investigational sequences that are not product by the vendor. A C2P is an investigational sequence from a non-vendor investigator, such as Peter Kelman. He had the T1 mapping MoCo WIP for C2P for a long time. That then often gets picked up by the vendor to become a WIP. They allow research groups to use the WIP and provide feedback while they implement it into their product pipeline. And eventually those WIPs become product. Not always, but often they do. But in the process of the life of a WIP, it will change several times before it becomes product. And so you want to be aware of, if you're using a WIP, what version of the WIP are you using? Are you comparing different WIPs to each other if you're doing multi-center work? Just something you need to be cognizant of. Another thing is just acquisition differences by vendors. If you're doing multi-center studies, you have the opportunity to say, we're only going to work with one vendor or one model scanner. But sometimes you have to widen that a little bit bigger. So you work with multiple vendors, multiple field strengths, and you try to homogenize the protocols such that they align really nicely across all the different acquisitions. There's going to be some variabilities, but we can account for that in the statistical analyses, as well as when we're doing serial studies, that patient gets scanned on the same scanner each time, so that removes the time varying component of having different vendor acquisitions. And then of course, even within something as simple as cine imaging, we have different sequences like our gradient echo and our TrueFist. When we do our analysis, we're going to document not only what type of sequence did we use, was it a WIP, what version. When we're doing the analysis, we do it in a consistent setting. We do it on a specific monitor resolution in low level lighting. We can set the window and level or the color maps to a specific and consistent setting. You probably seen this multiple times. If you do LGE analysis, for instance, what you call as LGE might be different based on whether somebody comes in and turns on the light beside you or has a bright monitor beside you. If they're looking at a white background on their monitor, it adds more light to the room. So we try to be very consistent with all of that. And then finally, we note any software differences. If there's a vendor software platform upgrade or a change in this analysis software that we're using, we will note that as well. And sometimes we have an evolution of methodology. We've seen this with pulse wave velocity, where we can do a 2D pulse wave velocity through plane, or we can do the aortic arch in plane and get the pulse wave velocity. So we have differences that we try not to change the analysis during this study, but when we make our plan for analysis, we consider these types of questions, we make a selection, and we tend to stick with it as much as we can so that we're not introducing variance into the core lab measurements. And one final thing that we do during analysis is we make notes to files. So this used to be a paper file note that we used to do for audit purposes. Now we can add it into our database. But we make any notes if we see a protocol deviation, if we see an artifact, if the septal wall was not motion corrected, so we exclude those segments in the analysis. We make those notes there for the database, and that allows us to, when we're doing our statistical analyses, we can go back and look at the image quality score and then the note to file as to what might have happened. So we're justified in excluding an outlier, but also using the notes to file allows us to highlight any protocol drift or deviations from a study site where we could engage that site in re-education or a protocol adjustment such that we have really high quality data going forward in the study. And the notes to file typically are, they're made by the analyst, and then they can get escalated up to the core lab director for identification of issue and resolution. And all of that helps in our audits and study closeout as well. So in conclusion, core labs can play an integral part in clinical research. We need to be cognizant of the acquisition of our exam, make sure it's high quality so we don't lose data. And when we do our analysis, we are being very specific in how we do it in order to ensure the quality of our measured outcomes for our research study or for another investigator who we are running the core lab for. So with that, I'll turn it back over to the CME slide and take any questions y'all have.
Jennifer, thanks so much for that overview. This is always a really helpful talk, I think, to go through, and not just from a research perspective, also clinical, think about our quality control and what all goes into getting the images that we do. I did have a question. You mentioned a couple examples throughout your talk of tweaking things at different sites when you're the core lab, and you mentioned maybe omitting a certain sequence or inadvertently having not enough slice offsets in the short axis stack. Are these the things that tend to be most common, or are there other sort of protocol deviations that are pretty common that you're having to tweak when you're acting as the core lab?
Oh yeah, I think that's mostly what we see because we do a big part of the education at the beginning and doing test scans and evaluating those. We have a lot of onboarding training with the sites. So when we are doing the study, what I'll see is maybe they got the T1 map and the base and the mid and not the apex. And so we'll go back to the site and we'll say, hey, make sure that you've got three slices set up. And something may have happened for that patient. Something was going on in the clinic that threw off that particular acquisition. But what we want to make sure is sometimes centers, they will pull up the patient's prior scan and just rerun that same sequence list. And so if it was omitted at their baseline scan, we want to capture that in the follow-up scan. So we make sure that they don't save that protocol to carry forward, that they have the correct one moving forward.
That makes sense. Thanks. Any other questions for Dr. Jordan? All right, well, we're finishing right on time. So thanks again, Jennifer. Wonderful talk. And thanks everybody for attending. We'll see you all back next week.
Thanks, y'all.